Assalamu alaikum wa rahmatullahi wa barakatuh, and a very good evening to everyone. I am Dr. Kanza Ahmed Chandio, CEO of Experience Dentistry, and it is my absolute pleasure to welcome you all to today's webinar titled When to Suspect a Malignancy and How to Manage It. This topic is not only crucial in modern clinical practice but also incredibly underdiscussed. It aims to empower us with the knowledge needed to make timely and potentially life saving decisions in our daily dental practice. We are especially honored today to welcome our first international guest speaker, Dr. Hadeel Kotat, an esteemed and maxillofacial pathologist who has done her MS and PhD in oral and maxillofacial pathology and is currently affiliated with Oroscope, Oral Diagnosis and Image Analysis Lab and serves as a lecturer in Misr International University. We are truly humbled that she accepted our invitation and has generously given us her time and expertise. Let me also take a moment to address something we deeply believe in at Experience Dentistry, the need for greater recognition and acknowledgement for oral pathology as a vital specialty. It holds immense potential for prompt diagnosis and improved patient outcomes, which is a dire need globally and particularly in countries like Pakistan, where delays in diagnosis often cost life. Through this webinar, we hope to build a stronger and more aware dental community that values early detection and interdisciplinary collaboration. Well then, without further ado, Dr. Hadeel Kotat, the stage is yours.
Thank you, Dr. Kanza. Thank you for your introduction. Thank you very much for the invite. I'm very honored to be here today. Let me just, before I start, is my PowerPoint apparent? Can you see it?
Yes, it's perfectly visible. Thank you.
Thank you, Doctor. Good afternoon, doctors and colleagues. I'm very happy again to be here with you today, and I thank Dr. Kanza for her invite. I'll be giving an overview on any alarming signs that you might encounter, and that would prompt a biopsy. At first, who am I? I'm Dr. Hadeel. I'm a lecturer of Oral and Maxillofacial Pathology at Misr International University. I'm also an oral and maxillofacial pathologist at Oroscope Lab. I'm based in Cairo, Egypt. Let me first give a very brief overview on oral cancer. As we all know, oral squamous cell carcinoma is the most common type of head and neck malignancy. According to data collected by the Global Cancer Observatory, there were around 400,000 of cases diagnosed in 2020 alone. Now, this tells us that this cancer is quite prevalent and requires our attention as clinicians and healthcare workers. The WHO ranked oral cancer as the 13th most common cancer worldwide, and that's as of 2023. Now, it's relatively well established that oral squamous cell carcinoma is more common in males than in females, particularly middle-aged to elderly males. However, interestingly, in Egypt, that's not the case. In fact, the WHO reported that most cases occur in females. Now, oral cancer has many faces. It could appear as a white lesion. It could appear as a red lesion, a speckled lesion, meaning parts that are red and parts that are white. It could appear as an indurated ulcer. An indurated ulcer simply means an ulcer that's firm on palpation. It could appear as an exophytic mass, and usually those masses, the surface is usually ulcerated as it shows here. It could also appear as a verrucous lesion. Another way is that it could appear as a non-healing extraction socket, and that's actually quite common. Now, what are the common sites? The most common site is the posterior and lateral border of the tongue. It accounts for around 50% of all cancer cases, followed by the floor of the mouth, the soft palate, the gingiva, and finally the buccal mucosa. However, the most concerning areas amongst all that is the lateral border of the tongue and the floor of the mouth. We call them the high-risk sites. They are the most concerning. Now, symptoms, oral cancer as symptoms, it's very vague. They're very non-specific, and sometimes they're even asymptomatic in early cases. And that's why diagnosis is almost always delayed. The symptoms, as I said, they're non-specific. They could be pain, it could be discomfort. It could be that the tongue no longer is as mobile as it used to be. It could be, and that's again quite common, unexplained tooth looseness. The patient, despite having no periodontal disease, nothing at all, will complain of teeth looseness. And so I have to consider oral cancer as one of my differential diagnoses. Now, how to diagnose? Incisional biopsy still remains the gold standard in diagnosing oral cancer. But the question always remains of what to biopsy, when to biopsy, and where to biopsy. Now, there are general guidelines I will go through now. First off are erythroplakias. As I said earlier, one of the faces of oral cancer is that it could be a red patch. Now, erythroplakia is quite worrisome. Most cases, most red lesions, they display severe dysplasia and sometimes even cancer or invasion. Some actually call erythroplakias as dangerous oral mucosa because it's most cases displays severe dysplasia and mostly oral squamous cell carcinoma. And indeed, after biopsying this case, the diagnosis was squamous cell carcinoma. And so the first alarming sign is that if I find a red area, an unexplained red area. Another alarming sign is the presence of a speckled lesion that has red areas and white areas. Again, it makes me suspicious of high-grade dysplasia or invasion. And indeed, after this part was biopsied, the diagnosis was squamous cell carcinoma. Notice that I have to include the red area in my biopsy. I cannot just take the white area because I said earlier, red areas are more suspicious than white areas. Something else we have to look out for is the presence of a sharply demarcated border. This is another alarming sign, or the second alarming sign that we mentioned today. A sharply demarcated border most likely tells me that I'm dealing with a pre-malignant or a malignant condition. And so I look for the alarming signs, which is in this case, the sharply demarcated border. And then I pick out the most concerning area within the lesion. It could be the red area, like I mentioned earlier. And this is the area that I should biopsy. Again, what are other concerning signs? Red areas. Induration. If on palpation I found a firm area, again, I should include this part in my biopsy. And as I mentioned earlier, the speckled appearance, red and white areas. Now, if I were to ask you a question, in your opinion, which was most likely a frictional condition or an irritational condition, and which is most likely the pre-malignant condition? I won't be able to see the answers, but the answer is definitely B. This is a pre-malignant condition. Again, notice the sharply demarcated border. Unlike the frictional area or the frictional lesion, where the borders blend in with the normal mucosa, there is no sharp demarcation. And so I would not really think of a pre-malignancy. In cases of ulcers, ulcerations, I should always include the part of the normal mucosa. I never ever biopsy the center of the ulcer, because usually the center of the ulcer would show me necrotic tissue, non-specific tissue debris. It will not be diagnostic, and I will have to take another biopsy. And so I never biopsy the center. I usually, when I'm presented with an ulcer, I biopsy part of the ulcer, the margin of the ulcer, and part of the normal oral mucosa. It's like a wedge-shaped biopsy. Same goes with the verrucous lesions. I have to include part of the normal mucosa. You see, the spectrum of verrucous lesions is quite big. And for me to reach a proper diagnosis, I need a normal margin. And that's why I have to include it in my biopsy. Now, if I'm presented with an extensive lesion, a big lesion, I have to map out my biopsies. I have to biopsy multiple sites. And this is very important when I'm having a lesion, say invasion, that's coming out of a background of a pre-malignant condition. Let me demonstrate. We are here presented with the lesion. It's quite extensive, as you can see. Again, alarming signs. This is what we look out for. The first alarming sign is that I have a sharply demarcated border. Another alarming sign is that I have red areas in my lesion, and it could be indurated parts on palpation. Okay, so here is my sharp demarcation. And so I biopsy the most concerning areas, which was this area here with, as you can see, it's red, and this area here, which was indurated on palpation. Now, what would happen if I biopsy the wrong site? What if I biopsy those areas, for example? They might simply show epithelial dysplasia only, and so I will have a missed cancer diagnosis. And that's why it's very important to map out my biopsy sites when dealing with an extensive lesion, as we can see here. Other general guidelines is that we always submit our biopsy in 10% buffered formalin, and the volume of the formalin should be around 15 to 20 times greater than the tissue volume. And general rule is that it takes around 1 hour per 1 millimeter of tissue for the formaldehyde to penetrate the tissue. And that's why bigger specimens should stay in formalin for a longer time to allow it to be properly fixated. Now, how do I prepare 10% buffered formalin? We usually add 1 part formalin to 9 parts water. I cannot use the ones that's sold in the market. Those are not buffered. It needs to be buffered so as to not harm the tissue. Now, let's talk. We gave an overview on what to biopsy when I'm dealing with something that's alarming. Now, what is an inappropriate biopsy? This is like a term that describes any error that I can encounter when attempting to diagnose a specimen. Now, they are classified into sampling error, insufficient tissue for diagnosis, and missing clinical data. Now, sampling error, one reason is that the incisional biopsy is not representative of the lesion. Examples like the ones we said earlier. Example, you have a mixed lesion and you chose to biopsy the red area and you chose to biopsy the white area and not the red area, which is mostly concerning. Or you have a soft tissue swelling coming out of a deep bony lesion. So you biopsy the soft part and ignored the intrabony lesion. Another example, and we actually see it quite often, is that you have an intrabony lesion and the surgeon chose to biopsy the perforation site. Again, it will deem not diagnostic. I will only see necrotic or severe infection coming out of the perforation site. You biopsied one portion of a highly heterogeneous lesion, as we discussed earlier. Something very important, that you chose not to biopsy a clinically suspicious lesion. This is very important. Most lesions that look clinically suspicious, they're not always malignant. It could simply be an inflammatory condition. A very common example is necrotizing cyalometaplasia. This looks malignant. It looks quite query, like you would look at the lesion and you would think it's malignant. However, it's simply an inflammatory condition. And the only way to find out is through a biopsy. And actually, cyalometaplasia's treatment is excision. So the only way to rule out anything concerning is through an incisional biopsy. The golden rule that we like to follow is that if a lesion stayed for up to 2 weeks and that did not regress despite removal of all the possible risk factors could be a sharp tooth, risk factors could be an ill-fitting denture, it could be a broken down restoration, it could be traumatic occlusion, it could be a lot of things. If I removed those possible causes and still the lesion remained beyond 2 weeks, this prompts a biopsy. I have to exclude the malignancy through a biopsy. Again, if I'm presented with a suspicious looking lesion, like the examples I mentioned earlier, clinical examination alone is not enough. I need to perform a biopsy. Now, what if I can't? What if I'm a general dentist and I can't? I can simply refer the patient to a specialist. I cannot ignore it. I have to refer the patient if I'm unable to perform the biopsy. Like I said earlier, biopsy should be taken from the most indurated part of the tumor if I am presented with an area that's indurated. If I'm presented with an ulcer, again, I never biopsy the center of the ulcer. I have to include part of the ulcer margin, and part of the normal tissue. Now, insufficient tissue for diagnosis, it could be two things. It could be insufficient in size, it could be insufficient in depth. Insufficient in size, let me show you an example of a slide. Now look at how small the tissue pieces are now. If you can't see anything, how can we as pathologists be any different? So it's very important that the size of the specimen, it should conform with the size of the lesion. Insufficient depth, like if I am presented with a case here, if that lesion was taken, for instance, a shallow biopsy was taken, this lesion would simply show epithelial dysplasia. However, this case hides invasion and cancer. So depth is very important. Depth is also important for me to assess the depth of invasion, which is an important histological prognostic factor that I have to report in my pathology report. And so depth is very important. Missing data. Now, people always think that pathology is only about the histopathology, it's only about the slide, and this is not true. It's a puzzle. I need all parts of the puzzle for me to be able to perform proper diagnosis. If one part of the puzzle is missing, it will obstruct the entire diagnostic process. Let me demonstrate with an example. We were recently presented with this case at Oroscope Lab, and that case was diagnosed elsewhere as peripheral giant cell granuloma. However, the lesion continued to grow. There was a swelling, an apparent expansile swelling, even though it was already diagnosed as peripheral giant cell granuloma. Now, after examination, an X-ray was performed, and it showed a well-defined expansile radiolucency crossing the midline, as we can see. And after histopathology, we reached the diagnosis of central giant cell granuloma. Now that completely changes the treatment plan. Like, peripheral giant cell is a completely different entity than central giant cell granuloma. And that just goes to show the importance of thorough examination and correlation, histopathology with the radiograph and the clinical picture. And of course, with this case, parathyroid hormone test was performed to exclude hyperparathyroidism. And that's how we reached our diagnosis of central giant cell granuloma. Now, allow me to present a few cases, real life cases. We were presented here at our Scope Lab. The first case was that of a 23-year-old male. The lesion was on the labial gingiva. The patient was a heavy shisha smoker. It showed white adherent patches spreading across the upper labial gingiva of 3-month duration. Now, if you look here is the white patch. Notice the sharp demarcation, and it was on both sides. Now, an incisional biopsy was performed on both sides. We took on both the right and left side and sent for evaluation. Now, histopathology revealed obviously a slightly verrucous lesion because parts of the lesion was more or less papillary, and it showed dysplasia, moderate to severe dysplasia. And actually this dysplasia was quite tricky because on the cellular level, the dysplasia wasn't as apparent as the architectural signs of dysplasia. Now, seeing, like I said earlier, it's a puzzle. I have to correlate the clinical picture with the histopathology. Now, the clinical picture showed bilateral white patches with the verrucous areas that led to the diagnosis of Here's another histopathological picture. Notice the severe architectural signs of dysplasia. Now with that, we reached the diagnosis of proliferative verrucous leukoplakia with moderate dysplasia. Again, PVL, it's quite common in females, non-smokers. However, since we have to correlate the clinical picture with the histopathology, this is what led to our diagnosis of PVL, even though it doesn't really match the criteria, the theoretically. However, correlating that with the clinical picture led to this diagnosis. Another interesting case was that of a 40-year-old female. She came complaining of a large, dull aching ulcer in the buccal mucosa. It's been 1 month, and it was on the level of the occlusal plane. If we can see here, this is the ulcer, and parts were slightly exophytic and papillary. We biopsied this area, and part of the ulcer with the margin was also biopsied. Histopathology revealed invasion. There we can see here, this is part that shows the ulcer, and those are the invasive islands. Again, invasion, invasive islands, and that led to our diagnosis of moderately differentiated squamous cell carcinoma. The last case is actually very interesting. It's that of a 57-year-old male complaining of a nodule that appeared 2 years ago on the lateral border of the tongue. It was non-responsive and it was gradually enlarging. Again, it prompts a biopsy. Here's the clinical picture. And a biopsy was performed. But histopathology revealed something interesting. It revealed necrosis and inflammatory cells, severe inflammation. And it was mostly that of eosinophils that led to the diagnosis of traumatic ulcerative granuloma with stromal eosinophilia, which is a deep form of traumatic ulcer. And again, this just goes to show that not all suspicious looking lesions are cancerous. And the only way to find out and the only way to rule out a malignancy is through a biopsy. So for us to conclude our lecture, still, biopsy remains the gold standard for diagnosis. Clinicians should remain vigilant during oral exams to find any suspicious lesion. And again, as I said, you either biopsy it immediately or refer it to a specialist. Any lesion that looks suspicious and doesn't resolve in 2 weeks must be biopsied. Despite removal of any cause, any possible risk factor, doesn't resolve, I must biopsy. And that early identification and diagnosis are our clinical goals. Thank you very much, and I'm here if you have any questions.
Dr. Hadeel, that was a brilliant presentation. There were so many clinical tips that we as general dentists could perform and be vigilant about. And so I would like to deeply thank you for such an enlightening and impactful session.
Thank
Now
you.
we'll open the floor to the questions. Okay. So if you have any questions, audience, please feel free to drop them in the comments. And let's take this opportunity to clarify, discuss, and learn directly from one of the leading minds in oral pathology. Yeah. All right. So also please try to keep your questions concise so we can cover as many questions as possible. Okay, so let's see. We have first question. It says, how to identify clinically tooth mobility due to carcinoma?
How can you come again, please, Dr. Kanza?
How to identify clinically tooth mobility due to carcinoma?
How do I identify clinically?
Yeah.
Can you write the question?
How is clinical tooth mobility differentiated from the carcinoma? Do you want me to present the presentation?
Yeah, please.
Okay, I'll do that.
Oh, how do I identify clinically tooth mobility?
Yeah.
This is, you actually can't. The only way to find out is through a biopsy. Plus, with the clinical examination, if you're presented with a patient that's good oral hygiene, does not complain of any gingivitis or periodontitis, it's quite apparent when tooth mobility is related to periodontitis or something else. And so the only way to find out is to perform proper clinical examination, perform an X-ray. This is very important, and a radiograph is very important. And lastly, you can perform a biopsy. Some people like to start conservatively by performing oral hygiene measures first, prescribing a mouthwash, performing proper scaling and curettage, and see the response. But if you performed all of that and yet things are not looking good, this is when this prompts a biopsy.
Right, definitely. I hope that answers your question, Mr. Abdul Rahim Ayman. We have next question. Miss Laiba Iftikhar is asking, what is the optimum depth for biopsy and how can we know it?
Optimum depth, if you're dealing with a gingival lesion, you have to go down to the bone. That's what we usually do. You have to go down to the bone, to touch bone until you're 100% certain that you got a proper tissue depth. You have to be certain that you include a part of the epithelium and the underlying connective tissue. You have to include the entire thickness of tissue.
Okay, right. Ms. Laiba, I hope that answers your question. We have next question, and I'm sorry I can't pronounce her name, but the question says, I heard that taking a biopsy from malignant lesion could help in its migration to surrounding areas. Is it true?
Yeah, I hear this a lot. I hear this question all the time. If I'm presented with something that looks suspicious, should I biopsy? Should I not biopsy? No, this is completely mistaken, a mistaken myth. You have to biopsy. And this is according to evidence. Like that's what the paper says. Papers say, for me to confirm that this is malignant, I have to biopsy. That's the only way to find out. Because as I said earlier, some lesions, purely inflammatory lesions, can look malignant. And so the only way to find out is through a biopsy. But seeding of cells from a malignant lesion, this is not correct. This, you need to, if it's performed well and you followed all the guidelines, then nothing's going to happen. But you need to biopsy. That's the only way to diagnose the condition.
I hope that busts the myth that we are surrounded with, that no,
I hear
taking the
this
biopsy.
question all the time, and
Right.
people are always worried to biopsy suspicious looking lesions, but that's not true.
I hope now we can practice well biopsies and refer properly and practice the interdisciplinary practice in our dentistry.
Precisely.
Okay, so next we have appreciation from Bithal, and she's saying PVL is very hard to diagnose and the case was very interesting. And
Thank you.
we got the comments
Thank you.
saying, wow, the presentation was really nice. Sarina says it was helpful enough. Then we have a question. This is a repeated question. Muslim Kids TV is saying it was a very insightful session. Muhammad Osama is saying, thank you so much, Dr. Hadeel, for the
Thank
presentation.
you, Dr. Muhammad. Thank you.
Okay, so we have a question from Mr. Teeth. It says, can biopsy increase the spread of tumor in some causes?
Again, according to evidence, I did not read that anywhere. The only way, how else will you diagnose the condition? How else? How else will you determine the treatment plan? Because again, oral squamous cell carcinoma does not just, the treatment doesn't only rely on excision. There is a lot of other factors to consider. And the only way to propose that treatment plan and perform it is from my pathology report. Because again, as I said earlier, depth of invasion, there's a lot of other prognostic factors that oncologists need to consider when proposing the treatment plan. And so the only way to find out is through a biopsy. And again, if performed well, it will not seed tumor cells. It won't do that.
Um, well, Mr. Teeth, take a word from our PhD expert, oral pathologist, Dr. Hadeel.
She's again and again insisting that this is a myth and we should completely remove and take the biopsies appropriately to make a prompt diagnosis so that we can have better treatment plan and better prognosis of our own patient. And so, yeah, no, we should always take the biopsies and continue with it. I hope I'm saying right, Dr. Hadeel.
Yes, you are. Thank you.
Okay. So before I proceed to any further questions, just a reminder, the feedback form has been shared in the comment section. Please do fill that up, okay? And inshallah, the ones who have completed their registration and feedback form will receive a certificate for this lecture.
Thank you.
Next is Amira Gamal. Miss Amira Gamal is saying, great lecture, Dr. Hadeel.
Thank you. Thank
And
you, Dr. Amira.
then Ria Lohana is saying this was a very helpful session. And then we have Miss Hen or Mr. Hen saying how to differentiate clinically between a cancerous lesion and a pre-malignant lesion. Clinically.
Yeah, you again, you can't because they're very much alike. However, some premalignant conditions have specific features. Say oral lichen planus, for example, it looks quite specific, but again, the only way to confirm that this is lichen planus is through a biopsy. However, clinically, you can never differentiate between both. You can have it, you can have an idea, like most probably this looks pre-malignant. However, you can only find out through an incisional biopsy because even the smallest ulcers, like you would look at an ulcer, it looks very small, it looks very harmless. It could turn out to be oral squamous cell carcinoma. And so you
Hmm.
cannot really differentiate between both unless again the premalignant lesion is quite specific, like oral lichen planus, like other conditions. But again, the only way to find out is through a biopsy. You cannot really identify it clinically. It doesn't. It's not as reliable as a biopsy.
Hmm. Right. The golden standard still remains biopsy. Better be
Yes,
safe than sorry.
yes, yes,
I
indeed,
hope
yes.
that answers your question, Hansalu. The next question is that varicose leukoplakia is more common on the tongue or the buccal mucosa?
It's actually more common in the gingiva. It's more common in the gingiva and it spreads.
Okay.
If we're talking about proliferative verrucous leukoplakia, it's quite common in the gingiva and then it spreads. That's why it's called proliferative. It doesn't really stay in one site. It starts
Hmm.
to include other sites. And so it's more common in the gingiva. That's why it's kind of different than normal leukoplakia because regular leukoplakias are more common in the tongue. However, proliferative is quite specific. It's more common in the gingiva, unlike classic leukoplakia. Etiologically, it's not related to smoking, unlike leukoplakia, which is related to smoking. And so it's quite different than regular leukoplakia or
Hmm.
conventional leukoplakia.
Insightful. That is really insightful. That proliferative are mostly on the gingiva. Miss Nancy, I hope that answers your question. And then we have a comment from Nurhan saying, quite an amazing lecture and great tips. Thank you so much, Dr. Hadeel.
Thank you, Dr. Nurhan. Thank you.
Yes, this is what I've been saying, that the tips and tricks that you have presented in your lecture are really going to help clinically.
Thank you, Dr.
Okay.
Kanza. Thank you so much.
And then Ibtihal Ismail is asking, when should I do excisional biopsy and when not?
It depends on the size, doctor. Usually people like to perform an incisional first, especially if it's quite extensive, and then go for excisional. That's what we did actually in the PVL case. It was first we performed an incisional biopsy on both sides, and after our diagnosis, the patient came in and went for an excisional. So it really depends on the size, but if it's a small lesion, yes, excisional should be it should be done. However, if it's quite extensive and you're still not sure whether it's malignant or not, perform an incisional first, and then the surgeon would later on go on to perform excisions.
Right. If the lesion is big enough, so we should stick to incisional, and then if
This
it's
is what
small
yeah,
enough, we should go to excisional.
this is what I usually see. Yes.
Right. Right. Okay. I hope that answers your question. Hand is saying very beneficial lecture. Yes. Yes,
Thank
it
you, doctor,
was.
and thank you so much.
Mm, Robina Sharif is asking, I have seen a check. I believe Robina is trying to say cheek. I have seen a cheek bite today. It was also having white patches, but it was in the posterior with last molar. So then, how to differentiate between oral lesion and that of a cheek bite?
Okay, so first, examination. She will clinically examine the patient. And if the bite includes that part, that white part, then it's most probably related to cheek biting. And so she first has to treat that bite. She has to, they usually perform like the relief occlusion or perform procedures so as to prevent that biting. And then she would go for a follow-up of the case. If the lesion started to regress, then this is what we're dealing with. If beyond 2 weeks to 3 weeks, the lesion has not started to regress, I'm not saying it should fully heal, I'm just saying it starts to regress, then this should prompt her for a biopsy. And that's what I mean by golden rule of 2 weeks.
Right.
You remove all the risk factors, you perform all the standard procedure that you usually do, and then you follow up the case. If it didn't heal, if it didn't start to heal, again, I'm not saying it should fully heal, no, but it's starting to heal. This is what prompts you to perform a biopsy.
Right. In practice, it's very difficult to keep a follow-up with patient, and I believe it is the responsibility of us as healthcare workers to make sure that our patients are on follow-up, because they do not understand the severity of the lesion they may be facing, but we know what the possibilities could be. So it is our
Yes,
responsibility to stay on
something
follow-up
else.
and make proper
Something else I
diagnosis.
always tell people is that even if you're presented with a lesion in the, say, tongue, perform an examination in the entire oral mucosa. Make sure that the entire oral mucosa is well examined and not just the cheek coupling that the patient came in with.
Very true, very true. Ms. Rabina, I hope that answers your question. Well, moving on. Khushi Dambara is saying it was very helpful. Yes, it
Thank you,
was.
doctor.
Jeevat Kumar is asking, do you foresee AI-based tool playing a strong role in identifying potentially malignant lesions in general practice?
Yeah, I believe AI should help us, but it shouldn't replace us. I truly believe AI should never replace the human eye. Yes, it could help, of course, and it does help. I mean, a lot of AI models are being developed, but they should never replace us. They should always be like we should work hand in hand and not really replace us, because it's AIs, I believe, are quite objective, and pathology is very subjective, and so it requires the human eye. Just my opinion.
Right. So it can be used just as a tool, but not the
As an
replacement.
adjunctive tool, yes, just purely adjunctive, and not really replace us.
Right. I highly agree with that statement.
Yeah.
Shajivat, I hope that answers your question. Moving on. Haneen Fatil Bab is saying, very professional, very interesting, Dr. Hadeel.
Thank you,
And
Hani. Thank you.
Dr. Scam is saying, thank you so much for the good session.
Thank you.
Mr. Teeth is saying, nice lecture and very informative. I hope your question was answered. And Soulful Girl is saying this was very interested. Muhammad Zolba is saying informative presentation. We
Thank you,
have taken
doctor.
tons of questions for now. So I'm just gonna go through the comments now. Such a conclusive and insightful lecture. Definitely. Many thanks, Dr. Hadeel.
Thank you, Dr. Sara. Thank you so much.
Abdul Hafiz is saying amazing lecture. Thank you so much, ma'am.
Thank you.
Robina once again saying it's very informative. Thank you so much.
Thank you, Dr. Rubina.
And then it says, thank you for the very informative lecture, Dr. Hadeel by Mona.
Thank you,
I
Dr.
think,
Mona. Thank you so much.
I think that's all with the questions for now. We have taken tons of questions and we have answered tons of questions. Hopefully that was helpful to everyone. I personally hope that you all will practice better in your general dentistry and seek to the oral pathologist when concluding for a oral pathological lesion. For the now moving towards the closing remarks, as we draw this session to a close, I want to express my deepest appreciation to Dr. Hadeel for her time, effort, and generosity for presenting such a valuable and insightful presentation with us today.
Thank you, Dr. Kanza. Thank you so much for the invitation. Thank you. It's my honor. Thank you so much.
And it is our honor to have you on our platform. Um, I would like to thank all our attendees as well for showing up and engaging and your commitment to learning. Your presence here today strengthens our shared mission and it raises the standard of dental education and patient care, inshallah. Lastly, I cannot end without expressing a heartfelt message. And we, as experienced dentistry, stand in unwavering solidarity with the people of Gaza, and we strongly condemn the ongoing atrocities and injustice committed by the oppressors against the innocent civilians. As healthcare professionals and as human beings, it is our responsibility to stand for truth, justice, and humanity both in our clinics and beyond. May we
That's
always
a
use our
very
knowledge.
useful message.
Yeah, may we always use our knowledge and voices to heal and to help. Once again, thank you so much, Dr. Hadeel, and our attendees. Do you have something to say, Dr. Hadeel?
Thank you, Dr. Kanza. It was an honor for me to be here today. I was honored to get to know you, and inshallah, this would open future collaborations. Thank you so much. Thank you.
Inshallah. Looking forward to collaborating with you in future sessions as well.
Thank you so much.
With that, we will end our session. See you next time, everyone. Goodbye. Have a
Bye
good day.
bye. Bye. Thank you. You too. Bye.